Now I'm going to talk about sodium thiosulfate for protection from cisplatin-induced hearing loss, presented by Aislinn Álvarez Rendón, teacher Dr. John Moscoso. Background: cisplatin chemotherapy and surgery are effective treatment for children with the standard risk hepatoblastoma, but may cause considerable and irreversible hearing loss. This trial compared cisplatin with cisplatin plus delayed administration of sodium thiosulfate, aiming to reduce the incidence and severity of cisplatin-related ototoxic effects without jeopardizing overall and event-free survival.
Well, cisplatin is a chemotherapy agent that's used in the treatment of many childhood cancers. It's estimated that in the United States alone, every year over 2,000 children and teenagers are treated with cisplatin. It's been well known that it causes hearing loss in a proportion of patients. Younger patients are more at risk, where the incidence may be 70 to even 100% in some subsets, depending on the treatments. Teenagers a little less, but they still have other forms of hearing loss and ototoxicity, including ringing in the ears, for example. So it has a lot of impact. I think one of the reasons hearing loss is so important in children, in very young children, is that it's not just the hearing loss, but it impacts learning, language acquisition, development, psychosocial development, school function, and a whole host of things that impair quality of life, both short and long term. It's really a devastating problem. Well, cisplatin, the damage is caused by the chemotherapy itself, and also what are called free radicals or superoxide ions that damage the hearing apparatus in the cochlea. So specifically, there's damage of what's called the hair cells, and when those are destroyed by those substances I mentioned, that's what leads to the hearing loss. So sodium thiosulfate is a scavenger that inactivates those damaging substances that are produced by the cisplatin. And it's thought that the sodium thiosulfate, when it's given intravenously, makes its way into the cochlea and actually circulates in the fluid there to prevent the cisplatin and the other ions that damage the hair cells from achieving that effect.
Methods: they randomly assigned children older than 8 months and younger than 18 years of age who had the standard risk hepatoblastoma to receive cisplatin alone or cisplatin plus sodium thiosulfate.
Well, sodium thiosulfate was developed many years ago, actually in the 1960s, for different purposes, and it gained the attention of some very important researchers. One of the most important is Ed Newell, who was a neurosurgeon at Oregon Health and Sciences University. Dr. Newell's been working in this area for a number of years and did important preclinical work that showed that sodium thiosulfate, when it's administered under certain conditions to rats and guinea pigs and other animals, that it can actually prevent the hearing loss that's due to cisplatin. So based on that work, he's used it in adults and to a smaller extent in children, and that's what gained the attention of our study group in the Children's Oncology Group and the Cancer Control Committee. So because of the encouraging results from the preclinical work, sodium thiosulfate was selected as an agent to study in the Children's Oncology Group to try to prevent the devastating problem of cisplatin-induced hearing loss. In this study, ACCL 0431, it was a randomized clinical trial that was conducted over about a 4-year period from 2008 to 2012, where children were enrolled if they were going to be receiving cisplatin as part of their chemotherapy treatment for cancer. It was a randomized trial so that children were randomized either to a control arm where they received their chemotherapy alone, or they received their chemotherapy plus sodium thiosulfate given 6 hours intravenously after each dose of cisplatin. And then their hearing was measured at baseline when they entered the study, where it had to be normal in order to be enrolled, and then again prior to each cisplatin dose, but then the primary endpoint of the study was measuring it 4 weeks after the last dose of cisplatin that was to be given. And then hearing was compared from baseline to the primary endpoint of 4 weeks after the cisplatin was completed, and the percentage of patients who had hearing loss was ascertained. So our primary finding relative to that outcome was that hearing loss was dramatically reduced in the among the patients who received sodium thiosulfate. The baseline incidence of hearing loss in the control arm was about 56%, and in the group of patients who received sodium thiosulfate, it was cut in half to about 26%. So we were very, very impressed at the outcome in that arena. Other aspects of function that or effect that we measured were the effect on specific changes with hearing, with frequencies and thresholds. We found that the hearing frequencies that are most involved in human speech, which are 2,000 to 4,000 hertz, were among those that were improved or benefited by the sodium thiosulfate. And then we measured its effect on some other toxicities, such as blood toxicity and kidney toxicity caused by chemotherapy, where the changes were not as clear-cut as the hearing protection. We also did monitor survival in both of the groups. Our study was powered to really look at the hearing outcomes, so it was, the sample size was not really adequate to clearly understand all the survival outcomes. What we found was that in the group as a whole, both event-free survival and overall survival were not affected significantly, but in overall survival, there was a trend towards significance in the group as a whole, where those who had received sodium thiosulfate, the overall survival appeared to be a little bit lower. So we conducted a post hoc analysis in this sample, where we classified all of the patients who had a variety of different types of cancer as either having localized disease or disseminated disease, to try to understand if there was an effect on survival where it seemed to be most prominent. And we found in patients who had localized disease, which was about 2/3 of the study population, there appeared to be no effect from STS in either event-free survival or overall survival. The numbers were really almost exactly the same. However, in the disseminated group, there did appear to be a difference in that there was somewhat lower outcomes with those who had been treated with sodium thiosulfate. That was in the patients with disseminated disease, which was about 1/3 of the study population. So we're not, it's difficult to understand this exactly for a number of pharmacokinetic reasons. This is not an outcome that we would expect for sodium thiosulfate to interfere with the chemotherapy, but we can't exclude that possibility either. We have carefully looked at the types of patients who were enrolled on the study, those who were randomized to receive sodium thiosulfate, those who were randomized to receive just their chemotherapy regimen, to see if there's maybe some imbalance in randomization that might account for that difference. And we really are not able to discern, a clear imbalance of any sort that would explain it. So it's a difficult finding to reconcile with what we know about sodium thiosulfate, but it is one that I think does need to be approached cautiously. And at this point, we're unable to make clear recommendations on the basis of our study data as to what should be, how sodium thiosulfate should be used clinically or in the research setting or for future clinical trials.
Now results. Hearing loss of grade 1 or higher occurred in 18 of 55 children, 33% in the cisplatin sodium thiosulfate group, as compared with 29 of 46 and 63% in the cisplatin alone group, indicating a 48% lower incidence of hearing loss in the cisplatin sodium thiosulfate group. Adverse events. Grade 3 or 4 are adverse events occurring in 8–10% of the cisplatin sodium thiosulfate group, or the cisplatin group were grade 3 infection, 23% and 31%. Anemia, 20% versus 15%. Neutropenia, 17% versus 12%. Grade 3 febrile neutropenia, 14% versus 19%, and elevated liver enzymes, 7% versus 12%. Now the conclusion. The addition of sodium thiosulfate administered 60 hours after cisplatin chemotherapy resulted in a lower incidence of cisplatin-induced hearing loss among children with a standard risk hepatoblastoma without jeopardizing overall or even free survival.
Our central interest is the blood-brain barrier and how drugs don't cross the blood-brain barrier. And one of the most common tumors that get cisplatin, as you just mentioned, is medulloblastoma. And we were looking for a better chemotherapy to treat patients with medulloblastoma, which is one of the 5 tumors in children that get cisplatin. I mean, the majority of children with solid tumors either get carboplatin or cisplatin. We tested a relatively new agent that's an analog of cisplatin, because cisplatin is very neurotoxic if you open the blood-brain barrier. And we studied carboplatin, and it worked beautifully, both in tissue culture and in animals. And we proceeded to do the typical thing, which is a phase 1 trial. Much to our surprise, carboplatin with blood-brain barrier opening resulted in high-frequency hearing loss, just like it does with cisplatin without barrier opening. And one of the first patients who we treated was a college professor from the East Coast who had no children, and her main enjoyment, besides being married to David Schein, was teaching. And she had ovarian cancer, which spread to the left temporal lobe, which is the speech center of the brain. And to take that out would have sacrificed her speech. So that was not acceptable. So they came out to my office with no appointment, and a stack full of papers saying why she wanted to have chemotherapy with opening the blood-brain barrier. And we just at that time had the toxicity phase of carboplatin delivery across the blood-brain barrier. And so we told her she qualifies, it's a platinum-sensitive tumor, and we started opening her blood-brain barrier. And she did beautifully, as David points out, in her therapy, with one exception. She developed high-frequency hearing loss. And just as we've just heard, if you have high-frequency hearing loss, you can't hear in a classroom. But she was the professor. So this was really damaging her ability to practice. Her husband, David Scheim, worked at the NIH, and he assures me of two things. One, it was not government time. He said he searched the internet on his lunch hour, and he found an anecdote, and he's never been willing to tell me the details of how he found it, except that it was on non-government time. And it said that maybe the drug, which David Fryer pointed out, is the only indication really for it is cyanide poisoning. And it's almost never given to people. The FDA approval was in case there was cyanide poisoning. It was all based upon animal studies for FDA approval. He came out because his wife developed high-frequency hearing loss with a bottle of sodium thiosulfate and wanted us to give that drug to her, his wife. We had absolutely no data to say that that was safe, and we said we couldn't do it. And then he asked if he could put a few drops in her outer ear. And I said, no, we can't do that. We would breach all IRB rules. But his case being from the NIH, and the husband of a woman who got unexpected hearing loss, we went to the Department of Pharmacology, where, as was pointed out, the other thing that causes high-frequency hearing loss is an antibiotic called an aminoglycoside. And again, it's outer hair cells of the cochlea that get damaged. And this Dr. Bob Brummett was literally packing his office to retire when the head of otolaryngology and I tripped him up and asked if he could stay another month or two and test this drug that David Scheim had suggested. And modifying the paradigm from an antibiotic-induced hearing loss to carboplatin and cisplatin was done expeditiously because Dr. Brummett was the expert on the model. And the bottom line was, it worked perfectly. If you separate the carboplatin or the cisplatin in time and space, so STS doesn't cross the blood-brain barrier, and if you give it 6 hours later when all the platinum is gone, you still can protect the hearing. And we used his model, which was the guinea pig. Guinea pigs are hard to use if you're studying tumors. We had to also be sure that we didn't protect the tumor. And we did extensive studies, initially funded by the Veterans Administration, but subsequently by the National Institutes of Health. And that funding allowed us to do all these studies, both first in the guinea pig and then in the rat. And the bottom line is, if we separated the platinum, which has a half-life of less than an hour, from the sodium thiosulfate, which we found was most efficacious if we gave it 6 hours after, we separated in time and space. One of the most common tumors to get cisplatin is medulloblastoma, but the other 4 tumors that commonly get it are not in the brain, and so you have to have the time and have all the platinum cleared before you give the antidote for cyanide. And it took industrial doses, 20 times the dose that is given for cyanide poisoning. It was the dose that we found worked in people. And we did it. We didn't help Mrs. Ziffern, Dr. Ziffern, who was the patient. But we started based upon the animal studies, the tissue culture studies, all of which was done in our laboratory. We proceeded to do an efficacy trial, and we went with blood-brain barrier disruption and carboplatin. We went from 80% of the patients having hearing loss to virtually none, and from 50% hearing aids to virtually none. And indeed, we had the problem of having to consider to do a randomized phase 3 trial, but the Institutional Review Board wouldn't let us do it because they said there was no equipoise. I mean, if you have 50% hearing aids without the drug and none with the drug, it wouldn't be ethical, since there was no evidence in the patients that we did in the phase 2 trial that we interfered with tumor protection. So we published those results and were invited by the two major pediatric groups in the world, COG, which is the Children's Oncology Group, and by SIOP, which is this group, to give a lecture about what we did in adults, because this so tremendously impacted the quality of life of children with the cisplatin, in which 80% of overall are cured. But as you've heard, the toxic sequelae, particularly with regard to the hearing, is, quote, mild, but it's, as Christy pointed out, it's a really big deal. So we worked with a Dr. Pat Reynolds to make sure we simulated the situation in children with cisplatin, with tumors with cisplatin as opposed to carboplatin, and both to show that we could protect the hearing, which was easy, but we need to be sure that we didn't protect the tumor. And we did extensive studies. The best was actually done in Los Angeles with the help of my son, who was a medical student, and we tested the tumor protection, and there was none if you separated it by 6 hours, and the otoprotection was dramatic.